Hello everyone. So today we are going to discuss on uh, laryngeal lesions. Okay. So whenever we talk about laryngeal lesions, what you need to understand is laryngeal lesions can be divided into different categories. Okay. So today's first lesion we'll be talking about is vocal cord nodule. Okay, so what is vocal cord nodule? So whenever you look into the glottic area, you have these two vocal cords. Due to repeated striking of the vocal cords because of severe voice abuse, okay, usually seen in teachers, okay, or it is seen in certain professions like singers, okay, or it is seen in vendors, okay. So in these professions it is usually seen, and in this profession what happens is, due to repeatedly striking of the vocal cord with one another, you will see some nodular growth in the anterior junction, okay, in the anterior vocal cord, okay, and this is known as vocal nodule, okay. So how are you going to treat this condition? The treatment of this condition is simple. What you are going to do is, you're just going to go for a voice rest, okay, you're just going for a voice rest, and you have to go for a vocal therapy, okay. Vocal therapy means, suppose if you are talking in a very high pitch voice, you have to talk in a low pitch voice, okay, minute pitch voice, so that your it is given some time to heal, okay, some time is given to heal, so it resolves on its own. And if it doesn't resolve, and if you continue to shout a lot, okay, or you continue to continue with the profession, like you just keep on shouting, if you're a teacher or if you're a singer, you just take on your high notes even though you have your vocal cord nodules, it will actually lead to you have to actually land into MLS, that is actually known as microlaryngeal surgery, okay. So next condition, which is somewhat similar to vocal cord polyp or vocal cord nodule, is the vocal cord polyp, okay. So vocal cord polyp is actually unilateral and it is pedunculated. So you can see that I've drawn with my with this red color pencil, that the vocal cord polyp is actually singular, okay, it is a polyp, okay, but nodule, it is never a nodule, it is nodules, okay. So vocal cord nodules is a bilateral structure. It is seen in a glottic area in a vocal cord, right? And where it is seen? It is seen in the anterior one-third and the middle one-third junction, okay. Or actually your whole vocal cord is divided into anterior one-third, middle one-third and the posterior one-third, okay. So, and basically your posterior one-third is actually this is your cartilaginous area, okay, so it can be said that the posterior two-third and anterior one-third, okay, or it can say that in the junction between one-third, upper one-third, anterior one-third and the middle one-third. So the same, these are different languages, but the actually understanding is the same, okay. So why only in this area? Why not in the posterior area? Why not in the severely in the exactly anterior area? Why only in the middle? Okay, it is because this can be explained by the concept that whenever you talk, the maximum area of vibration is this middle area, okay. This is the maximum area of vibration. So I hope you understood the vocal cord nodule and vocal cord polyp, okay. So I would like to again I would like to go for a revision. So whenever you talk about vocal cord nodule, it is also known as singer's nodules or teacher's nodules, okay. It is seen in the one-third, anterior one-third, upper one-third and the middle one-third, at the junction of the anterior one-third and the middle one-third, as I've already showed you in this particular diagram over here, which I'm marking with green. Vocal cord nodules are actually bilateral and it is actually sessile, okay. It is sessile. So what is sessile? Sessile means it is like this, okay. But polyp, they are pedunculated. That means they have this stalk, okay. So polyp, they have a stalk and polyp are unilateral, okay. So initially voice test is tried for vocal nodules, but if in case it fails, you have to go for microlaryngeal surgery, okay. And next thing that you need to understand is, this nodules, what is the common presentation of nodules, okay. So nodules can be presented as, they might have hoarseness of voice, okay. So nodules will present as hoarseness of voice, okay. Whereas and polyp, how will the polyp present? It will also present with hoarseness of voice. But in the case of nodule, there is a history of profession. For example, she might be a teacher, she might be a singer, okay. But polyp, there is one history that, okay, I had been to one of the concert and I really liked that concert and I screamed a lot in that concert. So from the history also you can have one idea that be a nodule or a polyp. Okay, and on examination what will you see is you will see small whitish nodular swelling in both the vocal cords. So you have to write in this way: small whitish nodular swelling in both the vocal cords. That means it's bilateral in both vocal cords. Okay, so what you need to understand much more with this vocal cord polyp and vocal cord nodules are: nodules may be of equal size or larger and smaller nodules may be seen. Okay, it's not compulsion that here you have this nodule means the same size nodule is here. Sometimes this might be slightly larger, but you need to understand that both of these conditions are yes, they are bilateral. Okay, vocal nodules are bilateral. Okay, whatever be the size, they are bilateral. And polyp also I've told you about the location of the polyp, and what you need to understand about polyp is they are unilateral and they are pedunculated. Polyps are unilateral and they are pedunculated. And the definitive management of polyp is microlaryngeal surgery. Okay, it is microlaryngeal surgery. You don't have any other aspect. Okay, it is microlaryngeal surgery. Now let's talk about the other conditions of the vocal cord. Okay, now let's talk about we want to talk about a very important condition that is known as contact ulcer or pachydermal laryngitis. Okay, so contact ulcer, pachydermal laryngitis, or this is also known as erythroid granuloma, or this is also known as kiss ulcer. Okay, so what you need to understand is usually whenever we talk about the conditions of the larynx, we often say that the anterior part is the involved part. Okay, but the posterior part can also be involved. Okay, the posterior part, if it involves the posterior part, what happens is basically you understand from this diagram that if it involves the posterior part, that there can be actually an erosion in one part and there can be a depression. There can be actually an elevation, hypertrophy in one part and depression on the other part, like this. Suppose there is like this, and over here you have like this. So you can see in this particular diagram that I've made. Okay, so why is this important? You need to remember that this is actually a hypertrophied arytenoid. Okay, hypertrophied arytenoid. Okay, arytenoid. Any other condition where you will see a hypertrophied arytenoid, a swollen arytenoid, or mammillated arytenoid? Yes, you will see this in the case of TB of larynx. Okay, so what you need to basically understand is due to excessive voice abuse. Again, you have the concept of voice abuse. Due to excessive voice abuse, or due to smoking, or due to gastroesophageal reflux disorder, or due to trauma. Now, what kind of trauma? Trauma means basically endotracheal tube intubation. Remember, endotracheal tube intubation, if in case there's a trauma to your vocal cord, it can lead to instant contact ulcer, or it is also known as pachydermal laryngitis. Okay, but what about ET tube intubation for prolonged period of time? Prolonged period of time of ET intubation, about 2 to 3 weeks, more than 2 to 3 weeks, will lead to something which is known as subglottic stenosis. So subglottic stenosis is actually it's actually one of the later complications of endotracheal tube intubation. Whereas whenever you go for ET tube intubation, then what can happen is initially they can be actually a trauma to the posterior aspect of the vocal cord, and it can result in arytenoid hypertrophy. Okay, and that is actually known as pachydermal laryngitis. Now you need to understand one thing, that the most important differential diagnosis of this one is, I already told you, the similar mammillated arytenoid or swollen arytenoid is seen in the case of TB of the vocal cord, right? TB of the larynx. So the differential diagnosis is tuberculosis, and carcinoma. So to rule out this, you have to always go for a histopathological examination. So it is mandatory to go for a histopathological examination if you see a mass on the posterior aspect of your vocal cord. Okay, so on histopathology, what will you find? On histopathology, you will find that there is hyperkeratosis, and there is acanthosis. Hyperkeratosis and acanthosis. Okay, now you need to understand that pachydermal laryngitis or contact ulcer or kiss ulcer is not a premalignant condition. It is not a premalignant condition. not a premalignant condition. Can you say one condition which is premalignant? Yes, you can say that is adult onset papillomatosis. I will also talk about this in certainly. Okay, adult onset papillomatosis. This is actually a premalignant condition. Even the juvenile papillomatosis is recurrent. It is recurrent and it presents with a lot of problem with the respiratory system. But juvenile is not a premalignant condition. Not a premalignant. Okay, premalignant, but the adult one is a premalignant condition. Okay, so what you need to understand that the treatment for your pachydermal laryngitis is laser excision. It is laser excision. So you can go for a laser excision for pachydermal laryngitis, and along with that you need to understand that if it persists for a long time, then you have to go for a botox injection. Botox injection is given in the thyroarytenoid muscle. So in a nutshell, what you need to understand that contact ulcer pachydermal laryngitis is actually also known as peptic granuloma or contact pachyderma. Okay, peptic granuloma and contact pachyderma. So I'm telling you this all from my notes. Okay, I have my notes in front of me, and with the help of this notes also I'm telling you. And some are actually the things that is not written here, and I'm just speaking like this and I'm writing it, so do make your notes. Okay, so due to excessive voice abuse or reflux, there is a rubbing of the arytenoid with one another with hypertrophy of one side. And I told you rubbing of the arytenoids, and you can see that there is one arytenoid is hypertrophied and other one is it has an ulcer, but that is not a true ulcer, it is a pseudo ulcer. Okay, so it looks like this. Okay, somewhat the diagram is the one arytenoid is hypertrophied and the other area has a depression like this. Okay, so this is actually a pseudo ulcer. This is a hypertrophied arytenoids. Now, not a premalignant condition, give voice rest and anti-reflux medicine, laser excision, and if it persists for a long period of time, you have to go for Botox injection. Okay, go for Botox injection. Now let's talk about tuberculosis of the larynx. Okay, tuberculosis of the larynx. So what is the major etiology of tuberculosis of larynx? We know that tuberculosis results from Mycobacterium tuberculosis, right? And remember, tuberculosis is a painless condition. It is a painless condition. You know that cold abscess, which is usually seen in a spine, spinal TB or hip TB. Okay, so this area it is painless. But what happens in the larynx? It is very much painful. Very painful. Okay, and there are classical features that you see in the case of TB larynx, and we will have a separate picture model where we will be talking about this one. But for now, you need to understand that there is a turban type swelling of the epiglottis, which is known as turban epiglottis. This is known as swelling of the epiglottis. Okay, swelling of the epiglottis. And what you can see next is the hyperemia of the vocal cord. You can see that there is a hyperemia of the vocal cord. There is hyperemia of the vocal cord like this. Okay, there is hyperemia of the vocal cord, and there is mammillated arytenoid, enlarged arytenoids. One more thing that I want to say you over here is in the vocal cord you have a discrete structure. Okay, and this is known as moth-eaten or mouse-bitten. Okay, so discontinuous multiple ulcerations. So multiple ulcerations. Actually, ulcers must be made by red, but actually I'm making a hyperemic vocal cord. That is why I'm using this orange color. Okay, so this is known as moth-eaten, or this is also known as mouse-bitten ulcers. Okay, and you can see that this red is actually your hyperemic vocal cords. Okay, and what is this? This is your enlarged hypertrophied arytenoid. Okay, and what is this? This is your turban epiglottis. We will have a separate session on pictures. I'll be showing you these diagrams again. Okay, so make this diagram. So what are the different other things that you need to understand? That this laryngeal TB is actually seen whenever you just cough out things, right? So when you just cough out, whenever you have TB and you cough, when you just cough, there is hemoptysis, and that cough can actually be, that the acid fast bacilli can be actually that it can stay in at the area of a vocal cord, and because of which you can actually land up into laryngeal TB. Okay. And one more thing I would like to add upon here. One more thing, okay. One more thing, a very very important thing, that is this these you can go for actually culture of the secretions from your vocal cord. Okay, you just scrape it some you just take a sterile one, and then you just scrape it over there, and then you just send for AFP, and you can find that there will be mycobacterium. Okay, mycobacterium. Remember, the treatment modality is you have to go for anti-tubercular drug. Okay, anti-tubercular drug, ATT, anti-tubercular therapy. Okay, you have to go for anti-tubercular therapy. Remember that the swelling of this epiglottis is just known as pseudoedema. It is known as pseudoedema, as it is due to granulomatous infiltration of the epiglottis, because of which there is edema. Okay, so what you need to understand here is, here you have certain granulations. So we all know that TB is a granulomatous disease, right? So here what happens is, certain granulation tissue are basically embedded, because of which this looks swollen, and that is why it is known as torben epiglottis. Okay, so pulmonary tuberculosis is along with the tuberculosis of the larynx. Mycobacterium tuberculosis is secondary to pulmonary tuberculosis, as I already told you. Mode of spread is air droplet. As you cough out secretions, there is the embedding of the tubercular bacteria in your vocal cord, because of which there will be this one. Okay, and what are the symptoms? The symptoms are basically hemoptysis, okay, fever, malaise, odinophagia. There can be drooling of saliva. And because of the severe hyperemic vocal cord, there can be change in voice. Okay, change in voice, weak voice, change in voice, odinophagia, painful swallowing. Okay, confirmed by histopathology or biopsy, and treatment is by ATT. Okay, so there is no role of surgery unless patient is a professional singer and that there is a presence of any sulcus or a granuloma. So if there is actually a granuloma, or there is actually a sulcus, then you have to go for surgery. Like example, in the case of contact ulcer or pachydermal laryngitis, I did not say that you have to go for a drug therapy. Okay, or I did not say that you have to go for voice rest. Okay, if you try voice rest, and you go for an anti-reflux medication in the case of pachydermal laryngitis also. But if it doesn't heal, you have to go for a laser excision, because there is actually this it's also known as peptic granuloma, isn't it, right? But here, if it's a granuloma, you have to go for surgery. Okay, if there's no granuloma, and if there's simply all the features of swelling or hyperemia, okay, you just go for voice rest. Okay, voice rest will be enough for this one. So next topic that we are going to cover is Rinke's edema. So Rinke's edema is also a very very important topic. So what you need to understand is, the vocal cord is actually lined by stratified squamous epithelium. It is lined by stratified squamous epithelium. And in this vocal cord, what you need to understand is, all the area inlet of the larynx is actually lined by pseudostratified columnar epithelium, but this vocal cord is actually lined by squamous epithelium. That is why whenever there is actually there's a communication, right? So columnose like cilio stratified communication is there. Okay, so that there's a communication. And Rinke's edema is always secondary to smoking. So if you are a chronic smoker, or if you have GERD, okay, if you are a screamer, or if you shout a lot, you go for a vocal abuse, you can have Rinke's edema. So in Rinke's edema, what you can see is, you can look at the vocal cords, it looks like a bag of water appearance. And this bag of water appearance of the vocal cord, it makes your voice so weak. So you'll have hoarseness. You'll have so weak voice. Okay, and the major problem is, if this vocal cord is so enlarged, so much of edematous tissue, subepithelial edematous tissue. Okay, basically there is subepithelial accumulation of the edematous tissue. This Rinke's is actually the vocal cord. It has been divided into different layers, like superficial, stratified squamous epithelium. Okay, then you have superficial lamina propria, you have intermediate lamina propria, and you have deep lamina propria. Okay, and lastly you have the thyroarytenoid muscle. Thyroarytenoid muscle. Can you tell me one condition where we actually were injecting Botox in the thyroarytenoid muscle? Yes, I already told you in the front. You forgot? I also forgot. That is why I'm looking at it. Okay, see here. In the adult, in the laser excision, Botox injection is given into the thyroarytenoid muscle, in the pachydermal laryngitis. Okay, in the pachydermal laryngitis. I'm also a student. I also forget what to do. Okay, this thyroarytenoid muscle. In the thyroarytenoid muscle, what you do is you just go for a Botox injection. Okay, in that case, in pachydermal laryngitis. Here, what we need to understand is there is just this thyroarytenoid muscle. There's a layer of the. We are just talking about the layer of the and in between the superficial stratified squamous and superficial lamina propria, there is myxomatous or there is edematous fluid which is accumulated. Okay, myxomatous or there is edematous fluid. Okay, edematous or myxomatous fluid is accumulated in between the epithelium and the superficial lamina propria. Now, what is the treatment? Go for voice rest. Go for voice rest. Avoid smoking. Avoid smoking. Avoid smoking. And go for anti-GRD medications. Give PPIs. Pantoprazole, omeprazole, lansoprazole. Okay, so there are different prazoles group of drug, right? Now, if in case doesn't work, at the end of the day, you have to go for surgery, right? So, what surgery will you go? You will go for reduction glottoplasty. So, what is this reduction glottoplasty? So, this is a new word I learned just today. Okay, so reduction glottoplasty means you'll just give a nick in this epithelium. You will give a nick on this epithelium, and what you'll do is you'll just drain all the fluid which is present sub epithelium. You'll just drain all the fluid, and what you do is you just remove this area. Okay, that just leave it open. Okay, leave it open. Drain all the secretion. Initially, what we used to do is we used to actually cut the portion where there is accumulation of the fluid, and because of that, what happened was initially we went for excoriation. Okay, excoriation of the vocal cord, and because of which what happened is post surgery patient had a change in voice. Okay, the voice was not that good. That is why now there's a concept that you just what you do is you go for a microlaryngeal surgery where you just go for decortication. Okay, decortication, not excoriation. Okay, decortication. And that basically one more best word is reduction glottoplasty. Plasty means you're repairing, right? Glotto means glottis, right? Reduction means the edema is being reduced. So reduction glottoplasty. So I hope you won't be having problem with this one, right? And remember one more thing that initially you will just do first it is done in one side. Okay, one, because this ringis edema is always bilateral. Okay, it is bilateral, so it's done in one side first, and then after 3 to 4 weeks only it's done on the other side. Patient presents with hoarseness, patient presents with diplopia, weak voice, and sometimes if the ringis edema is so much that it obstructs the area of larynx, patient will have breathing difficulty also. There's dyspnea also, it might happen dyspnea also. And if it's just if it's enlarged, and if you just go for certain exercises and all where you need more oxygen, at that case also there can be dyspnea. So sometimes dyspnea on exertion is not just a stable angina. It can also be your ringis edema. Okay, a stable angina, unstable angina, and prismatic quintal angina or other types of angina also. But right now we need to understand that the change in voice, stridor, diplophonia. Okay, these are the different things. So what we have missed? We have not missed anything. I think ringis edema, edematous tissue or myxomatous tissue is seen in the ringis space, which is basically the subepithelial space. It involves the anterior two-thirds of the vocal cord. Posteriorly, if it is involving, it is basically tuberculosis and pachydermal laryngitis, right? And smoking, alcohol, hormonal imbalances, dust allergies are the most common causes, and remember it's more common to males. Okay, it's more common to males. Okay, and bag of water appearance of the vocal cord, and stripping of the vocal cord is done, but not excoriation. Okay, but the best method is reduction glottoplasty. Okay, stripping of the vocal cord, decortication, microlaryngeal surgery can be done, and incision in the superficial vocal cord, drain and suck all the edematous fluid which is present in subepithelial area and resuture it. Okay, resuture it. Okay. There's a condition where we cut, where we drain, but we do not suture it. It was in the neck area. Okay, it is. I think it is ranula. Ranula. So I'm actually thinking about ranula, because ranula, it has high rate of recurrence, right? So that is why we just go for marsupialization operation, where we cut and then we drain everything. Okay, where we stitch it and we do not resuture the gland. Okay. Okay, next thing that we need to understand is about pseudosulcus and different functional voice disorder, which we will be continuing in the next video. Thank you.